my name is Brianna Wright, and I'm completing this task as a part of Crisis and Trauma Counseling course for the School of Behavioral Sciences at Liberty University. This is my Traumatology PowerPoint assignment. The table of contents for this presentation are detailed below. The table of contents is continued on slide 3. The table of contents is completed on slide 4. We'll begin with an introduction to the assignment. An effective evidence-based treatment for post-traumatic stress disorder among young children that have experienced trauma is eye movement desensitization and reprocessing. This treatment is successful in part due to its adaptable nature. This intervention is not dependent upon the participant's cognitive or verbal capacities, making it suitable for varied developmental stages. Children with reduced intellectual capacities are at a greater risk of experiencing trauma and associated symptoms of post-traumatic stress disorder. This presentation will explore the effectiveness of eye movement desensitization and reprocessing as a therapeutic intervention for young children with intellectual disabilities that are experiencing symptoms of post-traumatic stress disorder. Next, we'll explore our traumatology topic in detail. There are several definitions related to the topic. You have intellectual disability. What this refers to is deficiencies in neurodevelopment, impairments to intellectual functioning, and decreased adaptive behaviors. Eye movement desensitization and reprocessing, also known as EMDR, was developed as a psychotherapeutic intervention for reduction of post-traumatic stress disorder symptoms in the 1980s. Intentional rapid eye movement patterns are utilized to promote the processing of traumatic experiences. It's a non-invasive approach as it does not require extensive re-exposure or discussion of distressing occurrences. EMDR is also a short-term therapy. It can be completed in as few as 8 phases. The term adverse childhood experiences is also known as ACEs. This refers to traumatic events that occur within childhood. These events can lead to functional impairments within the child. Caregivers are also often the perpetrators. Some examples of ACEs include divorce of caregivers, mental illnesses among perpetrators, which are typically caregivers, and neglect by caregivers. Another important term is trauma. Trauma refers to an experience that the individual perceives as threatening to their safety or well-being. Traumatic experiences may be singular in nature, which is termed as acute, or repetitive, which is chronic. Examples may include vehicular accidents, terroristic acts, or abuse and neglect. Post-traumatic stress disorder is our final important definition for the topic. Post-traumatic stress disorder is often referred to as PTSD. What this refers to is symptoms as a result of traumatic experiences. These symptoms are disruptive to life. They may include nightmares, avoidance, or hyperarousal, or a combination. The next section of the presentation is the population of interest. For this assignment, the population of interest is children ages 0 to 8 with intellectual disabilities and experiences of trauma that result in symptoms of post-traumatic stress disorder. Another important concept to understand when discussing this topic is intellectual disabilities. Intellectual disabilities refers to impaired intellectual functioning, an intelligence quotient score of 70 below, and impaired adaptive behaviors. Adaptive behaviors may include social skills such as interpersonal skills, conceptual skills, which include the ability to understand language, and practical skills, which include the ability to complete daily living tasks. The rates of intellectual disabilities on a global scale among children and adolescents is 0.22 to 1.55%. Rates of intellectual disabilities are found to be lower within high-income countries, and rates of individuals in the United States is 0.5 to 1.5%. There are certain risk factors for the development of intellectual disabilities. The likelihood of a child being born with an intellectual disability is exacerbated by some of the characteristics that serve as risk factors for experiences of childhood trauma. The mother's utilization of alcohol during pregnancy can result in fetal alcohol syndrome. The child's exposure to physical injury through abuse during early childhood can also result in an intellectual disability. The neglect of a child's medical or nutritional needs during early childhood can result in an intellectual disability as well. It is important to study this topic because of the profound development that occurs during early childhood, ages 0 to 8. During this time, significant neural, social, emotional, and physical development occurs. Children's spiritual, social, cognitive, emotional, and biological development can be interrupted due to trauma. Another important reason for studying this topic is the predisposition of intellectually disabled children to trauma. Children with an intellectual disability have a significantly greater chance, 300 to 400% higher, of experiencing trauma such as abuse or neglect than their non-intellectually disabled peers. Intellectually disabled children that experience trauma are more likely to experience post-traumatic stress disorder symptoms due to their decreased adaptive skills. Lower intelligence quotients are associated with the development of PTSD symptoms, and children with an intellectual disability have decreased access to trauma treatment. It's also important to examine this topic because there's a lack of treatment for the intellectually disabled. Intellectually disabled children's symptoms of PTSD are often missed or undiagnosed. Their symptoms are often attributed to their intellectual disability. As a result, they're referred to behavior-based treatments. When they are referred to therapeutic interventions, they're oftentimes ineffective due to the child's inability to build rapport because, as will be later discussed, they have difficulty building attachments with others. The next section to be addressed is variables associated with the topic. Protective factors include social support, higher levels of education, and secure socioeconomic standing. There are barriers to social support among intellectually disabled children, including child behaviors. Many children with intellectual disabilities exhibit behaviors such as aggression and destruction. These behaviors can place stress on the caregiver and reduce the likelihood of a secure attachment and increase traumatic instances of abuse, neglect, and isolation. The impacts on caregivers is further explored. As previously stated, the stress on the caregiver due to the child's behaviors is increased, and there's a less likelihood of a secure attachment and an increased propensity for abuse, neglect, and isolation. Risk factors for the traumatization of intellectually disabled children exist. These include low social class, intergenerational trauma, mental health issues among caregivers, substance abuse among caregivers, and incarceration of caregivers. EMDR is an ideal treatment modality for children in the early childhood stage, 0 to 8, because it does not require advanced cognitive or verbal development. This intervention can be used among children experiencing post-traumatic stress disorder symptoms at a range of intellectual abilities. The short-term nature of the treatment is well suited for young children with intellectual disabilities due to their reduced capacity for effective long-term participation. The intervention is dependent upon eye movement and does not require the child detail their experiences. This approach will also decrease the likelihood of re-traumatization. There are a number of modifications to EMDR which will increase the effectiveness among intellectually disabled children. These include increased practitioner involvement, reduced use of context language by the practitioner, utilization of the storytelling method, emphasis on the child's emotional and physical reactions. A specific modification mentioned is storytelling. Storytelling is applicable for children with intellectual disabilities. It's already been used among children ages 0 to 4 because their verbal and cognitive capacities are reduced. So how this works is the practitioner will deliver a story about the traumatizing event. Then the client's physical and emotional reactions are monitored closely. And this would be suitable among children with an intellectual disability because they have similar limitations as do children ages 0 to 4 without an intellectual disability. The next section is biblical integration. The church has great value in the recovery from trauma. Experiences of trauma among Christ followers lend themselves to the Christian community's healing through shared testimony. Wang identifies social support as among the greatest predictors of recovery from trauma. Children with intellectual disabilities oftentimes do not develop a secure attachment with their caregiver, so the spiritual support could possibly remedy this circumstance. In the Bible, there are scriptural references to social support. In Galatians 6:2, Christ encourages his followers to support one another. In Isaiah 43:2, Christ reminds his followers he is with them throughout all their circumstances. He is their social support, as is the church. There's a profound relationship between intellectually disabled children and the church. Intellectually disabled individuals' participation in religious services fostered a sense of community and promoted development and healing. Christ in the Christian church as a form of social support could increase the effectiveness of EMDR as a therapeutic intervention with young children with an intellectual disability. Within the Bible, there are numerous scriptural references to the healing of children. In Mark 10:13 through 16, Christ welcomes children, affirms their value, and he heals them. In John 4:46 through 54, an official begs Christ to heal his child who is near death. Christ simply says that he will be healed and it is done. Christ does not have to go visit him or anything such as that. His word is so powerful and final, and he prioritizes the healing of children. Spirituality is very important when it comes to supporting intellectually disabled children. As previously discussed, there is a difficulty with children having a secure attachment to their caregiver. So spirituality, it improves the quality of life of the individuals with intellectual disability. It also includes the family's quality of life, their ability to render care, and their coping mechanisms. Within the Bible, there are scriptural references for familial support. In 1 Timothy 5-8, the importance of providing for one's family is emphasized. In Ephesians 4:2-3, patience and gentleness are promoted as means of keeping peace within the family setting. And this is very much required when caring for children with intellectual disabilities. They sometimes have aggression. They sometimes have behaviors that are difficult to deal with, so it is important that the family lean on Christ and his teachings to be able to cope effectively and render care effectively to their children. The final section of this assignment is future research. Future research should address the prevalence of intellectual disabilities among children ages 0 to 8. Prevalence of intellectual disability among children ages 0 to 8 as a singular occurrence should also be examined rather than being grouped with all other developmental disabilities. Future research could also benefit from the comprehensive analysis of effectiveness of EMDR among children with intellectual disabilities experiencing symptoms of PTSD. The current body of research is limited to individuals without an intellectual disability or limited to adults with an intellectual disability. Children with intellectual disabilities are not analyzed thoroughly at this point in time. Children with intellectual disabilities, they just struggle to develop a secure attachment with a caregiver, and this decreases their ability to get effective care. Social support enhances the effectiveness of EMDR, and it can be found within the church. So the question is, would a strong therapeutic alliance enhance the effectiveness of EMDR? Future research could benefit from examining this question. The final portion of this presentation is the conclusion. Children with intellectual disabilities are at increased risk of experiencing trauma. They are prone to developing symptoms of post-traumatic stress disorder. Children with intellectual disabilities are also less likely than their non-intellectually disabled peers to receive adequate mental health care. Eye movement desensitization and reprocessing is an evidence-based therapeutic intervention that is appropriate for the population of interest. It's a short-term, non-invasive approach. It's adaptable to children with diverse cognitive and verbal abilities. This intervention when combined with a Christian perspective characterized by Christ's encouraging word and social support within the church, could yield improved outcomes for intellectually disabled children. To truly understand the value of eye movement desensitization and reprocessing, comprehensive analysis of the treatment when used on intellectually disabled children ages 0 to 8 who have experienced trauma and are exhibiting symptoms of post-traumatic stress disorder needs to be thoroughly examined. References used for this presentation are detailed on slide 43, 44, 45, and 46. All journals used are scholarly, peer-reviewed, and less than 3 years in age. Thank you so much for your time and listening to my presentation. Thank you.